good afternoon. I've been asked to speak about what's new in colon cancer screening and how to do a high-quality exam in the next 25 minutes. And I thought, just as a frame of reference for all of us, we should start by saying in the United States, in their lifetime, 1 in 20 people will be diagnosed with colorectal cancer. And so based on that highly prevalence of disease and of fatal disease, there's been lots of public health efforts for screening. In terms of updates for this particular meeting, we put out a colon cancer screening document from the U.S. Multi-Site Task Force just in late last year. And in that document, it was one of the first times that we ranked the colon cancer screening tests, and Tier 1 being a colonoscopy every 10 years, or Tier 1 other option would be a fecal immunochemical test every year. And so the tiered system, as opposed to the U.S. Preventative Services Task Force that said do any as long as people got screened, we felt strongly from the three societies that the data, the practice, the actual implementation of what's done is particularly colonoscopy and FIT, and that's what we should drive our decisions as a first-tier option. Importantly, the recommendation is to start screening beginning at the age of 50. This was a strong recommendation with high-quality evidence. And I think that we know that age. The reason I'm highlighting it here is that just last month, the American Cancer Society came forth with a statement and recommendation, and in that, with a qualified recommendation, they recommended that adults aged 45 years and older with an average risk of colorectal cancer undergo regular screening with either a stool test, high-sensitive stool test, or structural examination, depending on the preference and test availability. And so this was very new. In the societies, we recommend 45 years for African Americans, but outside of that, it's 50 years old. And so this was very big. It made lots of headlines. I'm sure patients may have asked you. And I think what we need to recognize is that this was a qualified recommendation as opposed to that 50 years being a strong recommendation. And nicely, the three societies put out a joint alert. So the American College of Gastroenterology and the AGA and the ASGE put forth a statement sort of to direct us how should we be responding to patients who are asking should they be screened at 45. Certainly it may not be covered by their insurance yet for 45-year-old average risk screening. And so in that they highlight the 45-year-old for African Americans is currently the recommendation, and that 50 and others, and they say that this was a qualified recommendation based largely on a modeling study that utilizing updated data on the incidence of colorectal cancer in younger people. So this is more modeling. This wasn't randomized studies or longitudinal outcome studies that drove the ACS's recommendation, but more modeling based on current incidence data in younger people, 45 to 50 years of age. And so the ultimate recommendation from our societies was that continue the 50 years of age, but we await further studies, and this should stimulate further investigation, and we will need to revisit this if those studies pan out. So with that being said, let's talk a little bit more about screening and how we're doing and the screening process in general. So are there any failures or potentially modifiable failures in the screening process to prevent death from colorectal cancer? This was a study out of Penn led by Chaik Dubeni, but was presented at DDW by Doug Corley as he was part of the investigation. So this was a retrospective cohort study from Kaiser, Northern and Southern California, where they basically looked at about 8 years of data and people who had at least 5 years enrolled in a health plan, and they wanted to see in the people who were screened versus the people who were cancer-free screened, were there anything, what happened in the screening process in people who were diagnosed with colorectal cancer who were screened? What happened in that process that failed that they ultimately went on to develop colorectal cancer? And interestingly enough, I think we have our biases of why we think people may get cancer after screening. The bulk of it was that 70% were not up to date with screening, so some of them never got screened. Some of them didn't get screened at appropriate levels, so about a third never screened actually, and then a third weren't screening at appropriate intervals, and then a very small percentage received an inappropriate surveillance screening recommendation. And then I think this is one that we need to focus on in our screening programs, is that close to 1 in 10 of them failed to follow up for a positive test. And this is something that I think we talk about a lot. We have lots of efforts, but just because we do a FIT example, for example, or a sigmoidoscopy, for example, or something, if the test is positive, we need to then make sure that this patient has the ultimate screening and test for removal of polyps and examination of the whole colon, which would be a colonoscopy. So that was 1 in 10 patients. And then about a quarter of them had colorectal cancer and died despite being screened up to date. So what this was labeled as was a failure of the actual screening test. So we missed something. The screening test itself had limitations. This is something I think that is part of my talk today I want to focus on, is actually how can we improve that 25% that people who are screened and screened appropriately and are up to date still go on to develop colorectal cancer. So I won't talk about that study as much more, but we'll certainly talk about some of the quality throughout the rest of my talk today. This is just to say, is colonoscopy, are we doing a good job? I think about 5 to 10 years ago, there was a lot of studies that said there wasn't much difference between a colonoscopy and a sigmoidoscopy in terms of reducing right-sided colon cancer. They were good studies that prompted us to revisit our quality. I think there's been a lot looked at since, and a lot of focus on quality since. And this study by a similar group out of Penn and Doug Corley, looking at the Kaiser population, looking at right colon cancers compared to no screening, screening versus no screening, we're reducing cancer death by about 60% in the right colon, and we're reducing cancer death in the left colon by about 75%. So we're certainly doing a better job in the right colon than we were, and we're showing that when people get screened compared to people who don't, we are impacting lives, we're saving lives. But we still have this sort of skeleton in our largest world in GI, which is our colonoscopy world and our colorectal cancer screening world, that there still are these high rates of interval colorectal cancer. And this was a study presented at last DDW, but then published since then, just recently, that told us as an endoscopist in our career, if our career is about 30 years long, how many patients do we expect are going to be diagnosed with an interval colorectal cancer. And I think when we think about it that way, it becomes very personal, or if we had those experiences, they're very personal. And they did this estimate linking it to ADR, which certainly we'll speak of more, but I think we all know as the adenoma detection rate. And they actually had it broken down into low ADR, median ADR, and high ADR. I'm showing you the median ADR here. And they also correlate it with your volume. So if you are a very low volume endoscopist performing about 115 colonoscopies in a year, in your career you will likely have at least one interval colorectal cancer in your patients who you've screened if you're meeting current quality thresholds of ADR, meaning 25%. If you're a very high volume endoscopist, you will have close to 10 patients in your career who will develop a cancer despite your colorectal cancer efforts if your ADR is meeting thresholds that are published, meaning 25%. So I think when we look at those numbers and that they tell us that we need to continue to strengthen the screening performance of colonoscopy and our own performance as the endoscopist. And that's where within the U.S. Society Task Force recommendations, we also made recommendations not only for the screening modalities, but that we should monitor quality within those modalities. So we recommended that physicians performing screening colonoscopy measure quality, including adenoma detection rate, and that physicians performing FIT monitor quality, such as adherence to surveillance and positive tests and such, or the cutoff values, or what is your FIT positive in your population? Are you getting annual examinations? Are they having them serial annual exams, or just one time? Because there would be poor quality if they're only having it once. So leading us then into talking about quality indicators for colonoscopy, certainly we know about bowel preparation quality, cecal intubation rate, adenoma detection rates, and more recently, complete polyp resection rates and polypectomy competency. I'm going to highlight some of these in the next few minutes, and specifically focus a lot on ADR, because this quality metric has been the most strongly correlated with interval colorectal cancer. This study has been discussed and is presented at most talks, but because it's very powerful in that it showed us the broad range of ADR in a similar patient population that could have providers having ADR ranges between 7 and 52%. And I think that furthermore, showing that variability, they showed that that variability also showed and correlation with interval cancer. So when endoscopists have a 1% increase in their ADR, so their ADR is improving by 1%, it was correlated with a 3% reduction in interval colorectal cancer risk and a 5% reduction in colorectal cancer-related death. And importantly, there was no threshold effect upon which the increases in ADR were without benefit. So the current threshold of 25% is really just a minimum threshold. And I think that this study also showed us that it's not just a plateau that you reach once you reach that benchmark, but that continued increases in ADR lead to reductions in both incident and death related to colorectal cancer. Furthermore, out of Poland, Professor Kaminski's group showed us that, okay, that was a snapshot in time. What happens if these endoscopists with their ADR improve their ADR over time? Do their patients subsequently and their populations have reductions in colorectal cancer, interval colorectal cancer, and colorectal cancer death? And indeed they did. They showed that in their group, most of their endoscopists after feedback and training did improve their ADR, and with that their populations had reductions in the incidence and death from colorectal cancer. So I've mentioned this, but the minimum threshold was updated in 2015 from 15% for women and 25% for men, up to 20% for women and 30% for men, so an average detection rate in your population of 25% for your ADR, and that's again a minimum threshold. And importantly, the current number or the current metric is on screening examinations, not FIT, not surveillance, not diagnostic, not someone who came in for screening, you did the exam, and then on discussing they've had intermittent rectal bleeding, so then they're not a screening patient. Those are things that make this difficult, but the metric is really supposed to be reflecting your screening patients. Again, not patients who had an inadequate prep or the surveillance or such. And the reason that I'm pointing that out is the screening ADR in a FIT cohort is actually 20% higher on average than the screening in an average risk patient population. So if you look at median ADR in this study, there was a 31% median ADR in the screening colonoscopy average risk and a 55% ADR in patients who had a positive FIT who then went in for screening. This is important because a lot of European studies and a lot of programs do FIT and then colonoscopy reflect the ADR in that patient population, and this 25% minimum threshold is really too low for that patient group. The other thing often we think, well, our patient population's unique. I am mainly having certain patient ethnic groups and female genders, and I have family history, et cetera. So I have younger people versus older people. So there has been one study to look at adjustments in risk factors and did it significantly change what the ADR should be. And outside of gender, risk factors really didn't matter for ADR. So thinking about race, age, and even they put family history and other comorbid risk factors such as smoking, obesity, it didn't really change what the ADR should be. So you shouldn't think that your practice is unique enough that ADR doesn't reflect your practice or your performance rather. ADR should be reported from all of us. There's been a lot of discussion about, do you include serrated polyps in your ADR? Should we have a sessile serrated polyp detection rate? And the answer is we do not include these in our ADR. That wasn't where the 25% was, but it's also premature at this time still to have a sessile serrated polyp detection rate out there. There's been several studies that have tried to correlate ADR with serrated polyp detection rates, and in general this was out of Joe Anderson's group, who's done so much work in the field of serrated polyps, and they said that in general, correlating it to minimum threshold ADRs of that 25 to 35% range, that clinically significant serrated polyps or proximal serrated polyps, so those splenic flexure and proximally, you have about a 7 to 11% range that you should have as your detection rate if you're looking at your rates. But I think we need to recognize that serrated polyp detection rates continue to be highly variable. This was a study out of Indiana University with Charles Cahy and Doug Rex that showed variable 1 to 18% polyp serrated polyp detection rates, and that the predominant factor that mattered in what this was, it wasn't that they had middle-aged women who they were scoping more or that they had better preps. It was that the endoscopist is who influenced the serrated polyp detection rate, that alone. And I think the other thing of why this isn't an established norm to add that 7 to 11%, for example, is because we just don't have a gold standard, reliable, reproducible, pathologic diagnosis of sessile serrated polyps. There's a huge variability in pathologists' reading of serrated lesions, calling them either hyperplastic or serrated, sometimes being biased by location, sometimes being biased by the endoscopist telling them in their report, rule out sessile serrated polyp. And that's because the basement membrane is really needed to make that diagnosis, looking for those boot-shaped crypts with serrations that go all the way down to the base, looking for those goblet cells at the crypt bases. And a lot of times the specimens the pathologists received are not oriented. They don't have this basement membrane. They may not have enough crypts to call. And so, and the criteria has changed despite the WHO releasing specific criteria. So I think because of these reasons, that it has not been instituted as a quality metric to date, and I think that there's still time before this will happen. But certainly awareness is a first step, so educating your pathologist about these lesions, prompting them that you're concerned about this is very important and a first step. This study out of Kaiser and Doug Corley's group showed it still, though, did vary significantly amongst endoscopists after dedicated pathologist training, but that it did increase, so something to think about. So how do we improve our ADR? I think I won't spend too much time, but split dose is a must. If we want to find these flat lesions, if we want to examine that right colon, split bowel dose split bowel prep is really standard of care, and I think that I can't overemphasize that. The other things that have been studied outside of prep are numerous. I think you could have a week-long conference and still not cover all the topics of what have been looked at to try to help us. At the end of the day, it's you, it's us. We are the ones who make the difference. It's the operator. So a few inspection tips that how I approach high ADR. My ADR is about 63% in the studies that I've done. With my withdrawal time is about 9 minutes on average. And so these are how I approach colonoscopy for a high ADR. Is first to know the signature features of adenomas and serrated lesions, to look for subtle lesions, and my mindset is really important that I think for subtle. I think that I'm looking for subtle, not obvious when I'm examining it. I keep a straight scope, clean the mucosa, but don't spend so much time with water and washing, clean and move on so that I'm efficient. I look behind folds, expand and collapse the lumen in a dynamic process to appreciate morphology changes. Have a plan, so I take time, but I have a plan and I'm efficient, and I spend most of my time in the right colon, examining it twice, either in retroflexion or forward view, and knowing when I need a little more help. So whether I need the lighting to change because it's dark, whether a cap is going to be useful in a case or whether I need chromoendoscopy. Those are things that studies have shown improved adenoma detection rates, particularly for low-level performers, and there's some cases where they could help even high-level performers. And then engaging in a quality assurance program, measuring my ADR, knowing what my performance is motivating to adjust it as needed. So looking for subtle lesions, it requires us pattern recognition. It requires the mucosa to be clean. The lighting needs to be optimal, high definition endoscopes. And then we need a good insertion and inspection techniques, looking behind folds, distending it, cleaning it. And as I mentioned, there are times when we need chromoendoscopy or a cap to help us appreciate a lesion that otherwise may not be. Knowing their morphology is important, so certainly the polypoid, pedunculated, and sessile are easier to see when in our view, as opposed to the non-polypoid, superficial, elevated, or depressed that are much more difficult to appreciate even when they're in our view. Knowing the signature features of adenoma outside of the morphology, what are we looking for? Well, we're looking for a subtle color differential. It's going to be more red. The vascular network is irregular. The innominate grooves, which are those pits and grooves we see in the colon, there's an interruption or an absence of those when there's neoplasia present. Area may be slightly friable. Why is that? Neoplasia is present, or the wall may be deformed because either it's not expanded enough or there's a neoplasia present or a depressed lesion present. So all things that I think about again and again as I'm withdrawing. Here's a video that I have shown before, but it highlights, I think, examination well. So there I'm looking for all those features, and what do I see? I see a deformity of the fold at the 6 o'clock, sort of in the middle of the screen now, position, and I'll go into that again in a moment. So now it's showing it again. I circumferentially am viewing the folds, and boom, this is more irregular, it's more red, there's a lesion there. Knowing those signature features of serrated lesions, why is there not vascularity? I think I have a pointer here, right? Why is there a loss of vascularity up there? Why is there mucus there when there isn't mucus other places? It's because that's a sessile serrated polyp. So these have also been validated and defined: a mucus cap, indistinct borders, cloud-like surface, irregular shape, dark pits. All of these are signature features of serrated lesions, and certainly appreciating them in their entirety is important, because even when these lesions are found, what we're seeing is they're incompletely removed because of the lack of appreciation of the entire lesion. And I think emphasizing the insertion is really important because it's key for inspection. You need a straight endoscope when you're withdrawing so that your withdrawal is controlled. If you're focused on torquing and having dials and things, you're not going to be focused on looking at the colon, because more of your physical and mental efforts are actually on the scope position rather than what we're looking for, which are those polyps. I'm going to move on from here. I showed this in the earlier one, but you can see this lesion in white light. You can really see it with chromoendoscopy. So this at least will allow me a definitive, delineated, complete resection of this flat non-granular lesion that I've encountered. So dye certainly accentuates subtle lesions. You can see the difference between the white light here and the chromoendoscopy photos in this superficially elevated, in the flat in the middle, and in the depressed. It really highlights that. This is just a video example saying why. So what does dye do? It accentuates the innominate grooves. So if there's a slightly raised area, if there's an interruption of those grooves, the dye just pops it out for us because it accentuates that. The dye pulls into the grooves, it doesn't pull into the polyp. Certainly in average risk patients, this is a recent Cochrane meta-analysis on this systematic review that shows higher adenoma detection rates with chromoendoscopy in average risk patients, so an odds ratio of 1.3 to improve detection of polyps. This is, why don't we do it? Certainly, I've done a lot of research on this, and I'm focusing a lot now on the implementation of it, and invariably this is what is said despite the data. It's messy, it pools, it's not needed with high definition, it's only useful in high-risk patients. Virtual colonoscopy is the same. There's no randomized long-term survival data. It's expensive, it's too dark, it takes a long time, etc. So These are all statements, not facts. They're opinions. We can overcome these because there is data to tell us it's still superior with high definition, that virtual chromodoscopy is not the same. And we don't have randomized long-term survival study data for colonoscopy, so we can just go sit down and not screen. But if we're going to screen, we should use the optimal techniques. So this is all those things, though, about the reality of time and the reality of cost, they are real. We're only reimbursed so much, and so if it costs a lot of money to spray a dye and it takes time away from our procedures, then that can be a barrier. So at this DDW, they actually presented an oral form. So you would take these pills with a bowel preparation, and it's methylene blue, and it stains your colon so that when you go in and you start to do your exam, the colon's stained for you. There's no technical component now of spraying a dye that's described as tedious or expensive, and would be potentially included with the bowel preparation, so you in your ASC or your hospital, you're not absorbing that cost. They showed in this multi-center international randomized controlled trial that methylene blue pills increase the ADR by close to 10% and also increase sessile serrated polyps compared to the placebo. So just in a few minutes left, what are some of our other tools? I mentioned the use of a cap. There's been a lot of research and trials done both in the United States and in Europe and Asia about the use of endocuff cap, for example. So this is, in addition to just the cap, this has these phalanges there that are used as like retractors. So when you go in, they're flat. They're part of the cap. But when you withdraw, if there's a fold, these phalanges actually retract that cap, and I'll show you in this video here. So they help you to look behind folds. There's been lots of studies on this, so many that there's been a meta-analysis of 12 randomized controlled studies comparing endocuff-assisted colonoscopy with standard colonoscopy. These were up to 2017. There's been even a more recent US publication since then. But in any case, ADR significantly increased with the use of endocuff, 41% compared to 34%. And this was in both this was particularly in low to moderate ADRs, what they called as less than 35% compared to greater than 45% ADR operators. And a reminder that adenoma detection rate is not something that is just innate. Just because we finish gastroenterology training or enter a program, we don't know how to find polyps. This does take time. And engaging in quality improvement programs, certainly getting feedback as to how we're doing, engaging in leadership training to improve it will improve and sustain our ADRs. I think I want to say that there is help potentially from computers down the road. If we think we've maximized the human capability of finding polyps, can computers help us? They do it on our phones for our faces. We use digital and artificial intelligence every day. Can we apply this to medicine, and particularly can we apply it to colonoscopy? This is a group AI for GI. They had a recent publication on diagnosis and presented the data on detection at DDW. So for example, this would be part of your monitor. It's a software program, and as you're coming out, you can see a heat map telling you, okay, look, there's a polyp there, and it will give you some indication that polyp on the screen. Here's another just example. It's very easy right now because I'm showing you the polyp, but if it was in a distance and you saw the heat map or the word polyp, it may guide you further to look in that area as an aid. There was a recent publication in gastroenterology on this from a Japanese group. I'll just show this briefly so you can get a sense. So this is a 2 millimeter polyp in the ascending colon. So I showed you the polyp. Now we're doing the exam, and now the computer is going to sort of highlight the area. It's giving you a percentage, and will make a red mark once the polyp is in your field. So not telling you exactly where it is, but telling you in this screen, there's a polyp, look for it. A lot of the industry and companies are early in this development, but it's a very hot topic. A lot of DDW presentations, posters were on this topic. I think it will be something that is part of our endoscopy armamentarium in the future and part of processors. So I think I'll finish here, but just to highlight that current issues in the U.S. colonoscopy for cost-effective colorectal cancer prevention is that some of us still are not measuring our ADR. Some of us still are not using split bowel prep dosing and using shorter intervals than recommended in terms of surveillance. And I didn't have enough time in my topic today, but ineffective polypectomy technique is truly an area that I think we should be our next focus of quality after we've spent a lot of time now talking about detection, and we're finding polyps better, and we really need to optimize how we remove them, and we certainly need to replace the surgical removal of benign adenomas with endoscopic removal when we have cost-effective data to show that surgical resection is really unacceptable in this day and age of 2000 to have a surgical resection for benign polyps. So that's, I think, the areas of quality that we can continue to improve on. I think I'll finish there based on time, but happy to take questions. And if anyone has specific questions about polypectomy competency, it was presented at DDW often. I think it's a future topic of quality. Thank you.
Thanks so much, Tonya. That was a great talk. We're also going to do another computer swap back, so we have time for.
Yes. Is there any data in all the negative colonoscopies of missed anal carcinoma? Because you don't talk about the anal carcinoma, which occurs in certain groups and are at high risk.
Yeah, I mean, I agree. Anal carcinoma is a much lower prevalence, so we don't have screening programs for it, but I couldn't agree more. I advocate we go through the anus every day, and I don't just put my finger in and start my exam. I actually start my exam in the anus with my endoscope looking. So I don't have data to answer your question, but I completely agree that we can do a better job at identifying more precursors to early cancer like anal intraepithelial neoplasia, condylomas, and certainly in high-risk patients such as the immunosuppressed HIV, they should be, if you see a patient and see they've not had such screening, then you should get them in the right high-risk clinic for screening if you're not someone who does that.
Awesome. Thanks so much, Tonya. I appreciate your time.
Thank you so much.